you very much for having me at this Congress and in this great city and country. Very exciting. So here we're shifting not to standard of care. I was asked to discuss what's coming in the future in terms of novel therapies and novel combinations in ovarian cancer. Now, I could go on for hours about this, so I'm not going to. So as a result, I decided to try to find sort of 3 examples of unmet medical needs in ovarian cancer. We've done great progress, but this is not good enough. We have to keep going. And so I thought I would give you 3 examples of where maybe we can do more. So my colleague touched on this earlier, immune checkpoint inhibitors in ovarian cancer. Are we getting any closer? Then the post-PARP setting. You've heard great arguments for the fact that PARPs are a real advantage. So a lot of our patients are going to get it probably in first line, and if for some reason they missed it in first line and second line. So all of our patients will have been exposed to PARP inhibitors. What can we do afterwards, specifically in those who maybe are progressing under PARP inhibitor treatment? And finally, platinum-resistant ovarian cancer is still the cause of death for most of our patients, and we really haven't made much progress. So where are we there? So first of all, immune checkpoints in ovarian cancer. It's a depressing topic. Where are we? Well, we have, I won't go into details, 1, 2, 3, 4 randomized phase 3 trials that are completely negative. These are negative trials in ovarian cancer when you add a PD-1 or PD-L1 inhibitor, and it doesn't matter if you put it in first line, platinum sensitive, platinum resistant relapse. It doesn't matter if you give it alone, if you give it with chemo, or if you give it with an anti-angiogenic. Okay, so where do we go? Is there any hope for the future? Again, there are a number of strategies. I'll just give you one, and again, because it's a good lead-on from what was mentioned earlier. Maybe we didn't test the right combination. We've been putting immune checkpoint with chemo plus Bev. Maybe that's not the right thing. And here we have some data from the Mediola cohort, which was quite interesting. Now, there's a small number of patients, but what they did is they took patients with platinum-sensitive relapsed ovarian cancer that was BRCA wild type, right? BRCA wild type. And there they gave him a chemo-free combination, olaparib, an anti-PD-L1 durvalumab, and bevacizumab as treatment. Okay, and these are BRCA wild type. Well, here with no chemo, what did they get? They got 87% response rate. Again, these are not BRCA mutated tumors. Okay, that's pretty encouraging. So again, it's a small study, but we need some positive results because we have got 4 studies in the frontline setting testing the combination of a PARP inhibitor, an immune checkpoint inhibitor, and possibly bevacizumab. And so maybe we have some hope for these studies that should be reading out fairly soon. So moving on from immune checkpoint inhibitors in ovarian cancer, because ovarian cancer is probably not the best candidate for that. We've done great strides with PARP inhibitors, okay? But most of our patients will have received them. Many will progress during PARP inhibitor. It's really an area of unmet medical need. So do we have any strategies there? Well, the first thing is, how about you've had a PARP, new progression, get platinum chemotherapy again. How about reintroducing the PARP? So PARP after PARP. How about that? We know Bev after Bev works, so how about PARP after PARP? And here there was the OREO trial, which was a randomized phase 3 trial that tested exactly that approach. Patients had previously received a PARP inhibitor, then relapsed, were offered a platinum chemotherapy, and responded again to platinum chemotherapy. And there the question was, if you reintroduce olaparib as a maintenance, is that better than placebo? Well, the trial was statistically significantly positive, right? You have an improvement from 2 and some months to 4 and some months. But really, is it clinically significant? And here, I don't know if I have a pointer. No, not sure I do. So you can see here that at the first scan, 50% of patients will have relapsed, whether they were under olaparib or placebo. And here I'm showing you the data on BRCA mutated. So putting a PARP inhibitor in again in patients previously exposed and have previously progressed under a PARP inhibitor really doesn't work very well. And actually, they don't respond to platinum either. So the post-PARP setting is going to apply to most of our patients. What do we do for them? What can we do? Especially when they're progressing during PARP inhibitor. And here there are a few strategies that have been explored, okay? One is, okay, is there any way, if a patient is progressing during PARP inhibition, some of these patients, their tumor will have regained HR proficiency. They were HRD, but under PARP, they've acquired a resistance mechanism that makes them no longer HRD, but actually HRP. Is there any way we can revert back to HRD and therefore restore sensitivity to a PARP inhibitor? And this was explored in this study with a CHEK1 inhibitor, okay? They recruited BRCA-mutated ovarian cancer progressing under a PARP inhibitor. And we know, it was shown to you earlier, that a lot of these BRCA-mutated patients are escaping PARP inhibitor because they're acquiring a reversion mutation, for example. Well, they recruited these patients progressing under PARP. They did a biopsy at trial entry. And what did they show when they did the biopsy at trial entry on these patients progressing under PARP? Well, that they were indeed HRP. They had gone from being HRD to HRP, and they knew that because they did a functional assay based on RAD51 foci. But basically, that's why they were escaping. Then they gave them a combination of the PARP inhibitor olaparib with a CHEK1 inhibitor, okay? And then they biopsied them 6 weeks later, and they restored HRD, okay? So great biomarker data and some activity. Again, half of the tumors roughly are decreasing, and these were all tumors progressing under PARP. You add the CHEK1 inhibitor and they respond. So interesting, again, early data. Similar approach was done with WEE1 inhibition, and the principle was the same. Patients progressing under a PARP inhibitor, they were randomized to the WEE1 inhibitor alone or the WEE1 inhibitor plus the PARP. The study was presented by Sharon Weston, and some activity, 25–30% response rate. However, I'm not sure that what this study shows. You see arm A, that's the WEE1 inhibitor alone, is 23% response rate. Arm B, where you combine it with olaparib, 29%. I don't know. I'm not sure that's so different. I'm not even sure you need to put the olaparib in here. Maybe the WEE1 alone would work, right? And in fact, that's probably an interesting approach. In patients that don't respond well to PARP inhibitors, we know, and again, my colleague mentioned that ovarian cancer that has cyclin E1 amplifications tend to not respond very well to platinum or to PARP inhibitors, okay? However, this amplification makes them very susceptible to replication stress. Without going into the biology of this, this makes them highly susceptible to respond to WEE1 inhibition. And this was tested in this study. They recruited only ovarian cancer patients with a cyclin E1 amplification, and that's probably 20% of our patients, and treated them with single agent WEE1 inhibition. And now that's nice activity, almost 60%, okay? So again, we know ovarian cancer is heterogeneous, and those that are least likely to respond to PARP, a lot of them are gonna have a cyclin E1 amplification. Maybe this is their targeted therapy rather than a PARP. Oh, thank you. Then the last setting I want to talk about is platinum-resistant setting, okay? We know that unfortunately, if our patient isn't cured, they're going to die, and they're going to die of platinum-resistant ovarian cancer. All our patients, their end of their pathway is platinum-resistant ovarian cancer, okay? And we need to make some progress here. The only progress we've made since I've been practicing oncology is bevacizumab from the Aurelia study, okay? Now this brought true benefit to our patients. You can see the curves. You add bevacizumab in a platinum-resistant setting to single-agent chemo, and we really improved things for them. That's great, but that was in 2014. We have to do better than that. We haven't done any, all of our studies have been negative since then, okay? Not a single one has been positive. So what strategies do we have? Well, we can do what all the other tumor types are doing, and that is trying antibody-drug conjugates, okay? Makes sense. Ovarian cancer remains a fairly chemo-sensitive disease. You know, it's not like melanoma where chemo doesn't work. Chemo works in ovarian cancer. So maybe antibody-drug conjugates might help. We all know what these are. These are basically you put chemotherapy with a linker and either an antibody or a ligand that's going to go target a membrane-based target on your tumor cell, be internalized and then released only within the cancer cell. There are a number in development, but in ovarian cancer, probably the most promising one has been targeting folate receptor alpha, okay? And there was a phase 2 trial with mirvetuximab, which is an antibody-drug conjugate combining a cytotoxic, which is DM4 tubulin here, and linked to a folate receptor alpha receptor. And in this study, they required that the ovarian tumors had to overexpress folate receptor alpha, okay? It works best if you have really overexpression, and actually the bar is quite high. The tumors need to have more than 75% of their cells pretty positive for folate receptor alpha. Anyway, there was a phase 2 study, and it showed a response rate of 32%. Now, that doesn't sound amazing, but actually in platinum-resistant ovarian cancer, that's a very nice response rate where we know single agent really doesn't work, and a lot of these patients had been pre-exposed to PARP inhibitors. So that actually led in the US to FDA accelerated approval, but that's a small phase 2 trial that doesn't work in Europe. And therefore, there was a large phase 3 randomized confirmatory trial called the Mirasol study, where patients with platinum-resistant ovarian cancer who had received no more than 1 to 3 prior lines of chemotherapy and had to be centrally tested for overexpression of folate receptor alpha. And they were then randomized to the ADC, mirvetuximab, don't ask me to say the rest of that, can't say it, every 3 weeks, so that on its own, compared to standard of care in the setting, which is single agent chemotherapy, and the investigator could choose if they wanted to do weekly paclitaxel or PLD or topotecan. And the results, the study is closed, and the results have read out. It's only a press release. We're waiting for the formal, but the press release says this is a positive study. There's an improvement in both progression-free survival as well as overall survival if you use the ADC alone compared to standard of care chemotherapy in platinum-resistant ovarian cancer. Now, this only applies to a minority of our platinum-resistant ovarian cancer patients because this degree of folate receptor alpha overexpression is only found in about 20%. But as the first step forward we've made in platinum-resistant ovarian cancer since 2014. So it's a start. So in conclusion, just taking 3 sort of examples of where we have still today unmet medical need. In terms of immune checkpoint inhibitors in ovarian cancer, we're having a lot of trouble, really. But the triple combination PARP inhibitor, immune checkpoint inhibitor, and bevacizumab had remarkable activity, 87% objective response rate with no chemo in relapsed ovarian cancer is really quite impressive. So we hope, fingers crossed, that that means that our studies in the frontline setting might read out positive. I think personally that we should be probably doing other immune strategies in ovarian cancer, but let's see how this goes. The post-PARP inhibitor setting is an area of unmet medical need. It's probably going to concern 80 to 90% of our patients, and we have no idea what to do after that. They don't respond to platinum. It's really tough to get them to respond again. So we need to see what can we do for these patients. And here it's early days, but restoring HRD with checkpoint inhibition is interesting. And some of these patients might have a molecular profile that makes them eligible to something like WEE1 inhibitors. And then platinum-resistant setting, finally we're seeing some light at the end of the tunnel with our first positive phase 3 trial in this setting since, in almost 10 years with an antibody-drug receptor conjugate targeting folate receptor alpha. We're still awaiting, I don't like press releases, so we're waiting the presentation and the publication, but I think, sometimes it's good, always good to have some good news. And on that note, thank you very much for your attention.